Hello, this is Dr. Daniel Bruns, and this is MIR Explained, Part 1, Introduction to the VHI-2 MIR Report. MIR, MIR, is an acronym for the Medical Intervention Risk Report. The MIR report is an interpretation of the VHI-2 tests. The VHI-2 test itself is fairly complicated, having quite a few different scales and measures. The MIR report analyzes the VHI-2 test item results in a new way. The MIR report is designed to be used for the assessment of medical patients within a biopsychosocial context. The purpose of the MIR report is to identify risk factors for a poor medical outcome and also to make suggestions for treatment. The MIR report is a cover sheet and about 4 pages of analysis, which creates a snapshot of how a patient is currently doing. I want to begin with some general considerations about the psychological assessment of medical patients. One way of thinking about interdisciplinary treatment is that it involves 4 different components. There are surgical and interventional procedures, where a patient is taken into an operating room and procedures are performed. There are also a great variety of medications that can be provided to the patient. There are also a great variety of physical therapies, not just physical therapy proper, but also chiropractic, occupational therapy, massage, acupuncture, tai chi, and so on. Lastly, there is behavioral medicine. The behavioral medicine component of interdisciplinary care can be thought of itself as having 2 components. One are treatments like CBT, mindfulness, and so on, and the other is behavioral medicine assessment. Behavioral medicine assessment has implications not just for behavioral medicine treatments, but also for the other 3 categories of treatments as well. There's a good deal of research showing that behavioral risk factors can predict the patient's response to various types of surgical procedures. Here I want to reference 3 noteworthy studies. First of all is the Dunboer 2006 study, which is a systematic review of psychological risk factors affecting spinal surgery outcome. This study was replicated in 2009 by Celestin and colleagues, who used a somewhat different method but came up with nearly identical results. Lastly, I was a co-author, along with Mark DeSorbio, of a study in 2009. In contrast to the Dunboer and Celestin studies, our study used not only systematic reviews, but also other studies and expert consensus studies as well. We'll talk more about this later in the presentation. Behavioral risk factors can also predict the patient's response to opioid therapy, and behavioral risk factors can also predict a patient's response to physical therapy as well. Thus, you can see that behavioral risk factors play an important role in predicting a patient's response to interdisciplinary care generally. So, when you're performing behavioral assessments of medical patients, what do you look at? When we reviewed treatment guidelines and expert consensus generally, the consensus seemed to be that there are 2 types of risk factors to look at. First of all, there are what are called primary risk factors, which you can think of as the psychosocial red flags, and there are also secondary risk factors, which would be the yellow flags. When developing the MIR report, we define primary risk factors as involving dangerousness to self or others, psychosis, or psychopathology above the 99th percentile when compared to other patients. Obviously, most patients have no primary risk factors. That's a good thing. But sometimes primary risk factors are present, and if so, that patient may be so psychologically unstable as to be unable to cooperate with treatment or to benefit from treatment. Whenever a primary risk factor is present, it's important to stop and reassess what you're doing especially if you're looking at an elective surgical procedure. In contrast, there are secondary psychosocial risk factors. These are the much more mundane risk factors like depression, anxiety, job dissatisfaction, worries, and stress generally. In contrast to primary risk factors, which are rare, almost all patients have one or more secondary risk factors. With a primary risk factor, even one can substantially interfere with the patient's ability to benefit from treatment. In contrast, with secondary risk factors, it's the number of risk factors present that you have to think about. As the number of secondary risk factors increases, prognosis worsens. Let's move on now to an overview of the MIR scales. I will first give a brief overview of them and then go into each one individually. The first measure on a MIR report is self-disclosure. This is a validity measure which assesses the tendency a patient may have to bias information. Self-disclosure assesses both the tendency to minimize that the score is this measure is low, or magnify if the score is high. And what self-disclosure is assessing is a tendency to minimize or magnify psychological difficulties. Next is the primary risk score. As the name implies, this assesses primary risks, which are, again, dangerousness of self and others, psychosis, or severe psychopathology. The remainder of the scales are all variants of secondary risk, and secondary risks as they apply to particular medical concerns. First is the presurgical risk measure, and related to this is the rehabilitation risk measure. We'll discuss the differences between these two measures shortly. Below them are two more related risk scores, the addiction history risk and the addiction potential risk scores. And lastly, there are two measures of problematic coping styles, which are catastrophizing and kinesiophobia. Now note that most of these measures are scales with two exceptions. The primary risk score and rehabilitation risk score are algorithms. Both of these, in essence, are an algorithm which produces a way of counting the number of risk factors present. And so, as opposed to having items, these two measures are both based on the number of risk factors present. The next presentation will be devoted to the MIR Psychometrics, but very briefly I want to review some things here. With regard to the MIR reliability, the alpha coefficients range from a moderate level of 70 to a very high 97. As you may recall, the alpha coefficient is a measure of internal reliability, which is also a measure of item homogeneity, or how similar are all the items. These scores range from a low of 0.7 to a high of 0.97. You should recall that alpha coefficient is also affected by scale length, and so our shorter scale, kinesiophobia, had the lowest alpha, and the longest scale, self-disclosure, had the highest. So to some extent, this is a function of scale length. The test-retest stability was all quite high, ranging from 0.88 to 0.96 for 1 to 2 week test-retest stability. Validity is a substantially more complicated issue, and we're not able to deal with it briefly here, other than to say that we did look at a variety of validity criteria, and in general, the effect sizes were in the moderate to large range. But again, for more information, you can refer to the MIR manual and also to MIR Explained Part 2. Let's take a look at the MIR report itself. Here's a view of the MIR profile. On the left, you can see are the names of the various MIR scales. In the middle of the profile, you can see a gray band, which is the normal range. It's plus or minus 1 standard deviation. Now, this is what's called a deviation bar chart. So the larger the bar, either above or below the mean, shows the degree to which a score deviates from the mean, either high or low. And like a CBC, a score typically falls within a certain range, and scores above or below average can be meaningful. Now, there's also a standardized T-score. This is the usual T-score, mean of 50, standard deviation of 10, a percentile rank that converts to, and also a rating. Let's look at a high-risk profile. Here you can see there are multiple bars that are outside the normal zone. 3 of these are secondary risk factors, or yellow flag scores. But one is the primary risk score, which is well above average. And that's a major concern. Also over here on the left side, you can see the raw score is 4. In this case, the raw score is significant, as it means that this patient reported 4 primary risk factors. Now, the MIR report will not just give you a raw score, but it'll also tell you what those risk factors were. And so this is a little excerpt from the MIR report. And so it lists 4 primary risk factors, and it tells you the categories they're in. So in this particular patient, the patient was reporting suicidal ideation, violent ideation, and also high levels of depression and hostility. Now, those are somewhat different than suicidal ideation and violent ideation, in that in addition to suicide, the patient was reporting depressive cognitions and affect above the 99th percentile, and also not just violent thoughts, but characterological chronic hostility above the 99th percentile. And hostility in this case is composed of items that involve cynical thoughts about others, difficulty with anger management, and aggressive behaviors. So all 4 of these risk factors are a concern. Now, if you were considering this patient for surgery, this patient is clearly unstable emotionally, and while a surgery might be elective, suicidal ideation is a potentially fatal condition. So when you're thinking about treatment plans, a condition that's potentially fatal should rise to the top of the list over elective procedures. Let's take a closer look at the MIR measures now, beginning with the MIR validity measures. The MIR actually has 4 different validity measures that it utilizes. First is blank items. For various reasons, sometimes patients leave parts of the items blank. There can be various motives for this. The patient might be uncooperative or just ran out of time. Now, with a lot of tests, a certain number of blank items will invalidate the entire test. Not so on the MIR. On the MIR, the scales are invalidated 1 measure at a time. So, if for some reason a patient left all the items on catastrophizing blank, then that measure is invalid, but the rest are not. And so this prevents you from losing all your information on the test if a patient refuses to answer certain kinds of questions. Next is random responding. The MIR has a validity index, just abbreviated V, and this consists of 4 really strange items that are rarely endorsed. Nearly all people will fail to endorse all of them. But sometimes people do endorse 1 or more of these bizarre items. And there's various possible reasons for that. It could be attributable to bizarre thinking, more commonly to illiteracy. The person just can't read. Maybe they forgot their glasses. Or it may just be random responding. If a person isn't invested in the test and is just marking in dots randomly. So if 1 or 2 is endorsed, there's a validity caution. If 3 or more are endorsed, that does invalidate the MIR. You wonder if the person was responding, in a rational manner. Finally, there is a measure of biased responding, self-disclosure that I mentioned previously, which assesses the tendency to portray oneself in an overly positive or negative manner. Medical assessment is heavily dependent on a patient's willingness to disclose personal health information. When you go to your doctor, you say, well, doctor, I've been having these symptoms. And if a patient isn't willing to disclose that, it makes medical assessment far more difficult. The self-disclosure scale assesses the patient's willingness to disclose psychological difficulties or dysfunction. Now, some of these things are a little bit abstract, and so we're going to use a cartoon, which I call Bob and Dr. Cutter. So Bob goes to see his surgeon, Dr. Cutter, and they have various conversations. So here we have Bob and Dr. Cutter in the exam room, and Dr. Cutter says, well, that disc at C5, C6 is herniated. That might explain the extreme pain in your right arm. And Bob says, the pain is killing me, Doc. So Dr. Cutter says, how are you coping emotionally with this? And Bob says, emotionally, I'm great. So the pain is killing him, but he's just on top of the world. This is the definition of somatizing or somatization, where people may overly report medical symptoms but underreport psychological ones. So it is kind of unusual that he's reporting these extreme pain symptoms but is emotionally doing so well. And that suggests this patient isn't disclosing everything that's going on. How do you interpret the self-disclosure scale? Low scores on this measure can imply one of 3 things. First of all, a patient may be unwilling to disclose personal information and be saying basically, none of your business. A low score can suggest a lack of psychological mindedness. The person may not be introspective, may not report being depressed because they don't know what depression is. They don't really understand what feelings are, and so they have nothing to report. Or sometimes a patient is motivated to appear especially virtuous for some reason. An average score on self-disclosure means that no disclosure bias was detected. In contrast, a high score in self-disclosure could suggest a patient who is magnifying his or her psychological difficulties, or can be a patient who is highly distressed and who is decompensating psychologically. Let's move on now to treatment-related risk assessment on the MIR. The primary risk score assesses 14 indications of dangerousness to self and others, psychosis, or extreme symptoms. As mentioned before, it's scored by an algorithm, with points awarded for suicidal or violent ideation, both of those get a point, hallucinations or paranoid ideation, pain or somatic symptoms above the 99th percentile, and psychopathology above the 99th percentile. Now, most patients get the lowest possible score on primary risk, which is 0, fortunately, but some do have positive scores here, and any score above 0 is important to look at. So when interpreting the primary risk score, an average score means no primary risk factors were reported, which is a good thing. That's what most patients report. A score of high or above means that one or more extreme risk factors were identified, and these should be investigated further with interventions taken as appropriate. Next, there's secondary risk factor assessment, and the MIR has two treatment outcome risk scores which utilize secondary risk factors, which are presurgical risk and rehab risk. So why do we have two? Let's look at the literature. As noted before, there are two major systematic reviews at this time of spinal surgery outcome, which identified 9 or 10 behavioral predictors, depending on how you categorize them, of poor surgical outcome. That's the best science available at this time. However, if you look at expert consensus, there are many variables that have never been researched that experts think are probably more important than the Den-Boer criteria. Now, to help think through this, let's talk to Bob and Dr. Cutter. So, Bob and Dr. Cutter are talking, and Dr. Cutter says, okay, the psych eval says you have extreme pain for 6 years, severe stress symptoms, depression, anxiety, have difficulty coping, and you feel totally disabled. Bob says, yep. And Dr. Cutter says, okay, based on a study done by a guy named Den-Boer, with these risk factors, odds are that surgery won't get you the results you want. Other treatments are more likely to be helpful for you. So, that's looking at the Den-Boer criteria, but suppose we had a different result from the psych eval. Here, Dr. Cutter says, okay, the psych eval says you recently were incarcerated for drug offenses, you have an antisocial personality, you're currently using meth, and you have paranoid hallucinations. Oh, and also I see you're suing your last surgeon for malpractice. Bob says, yep. Dr. Cutter says, that's great. Using the Den-Boer criteria, you have 0 risk factors. But he also wonders, geez, am I overlooking something? So the problem with the Den-Boer risk factors is that all these things like antisocial personality, drug offenses, intoxicated on meth, none of those factors have been studied in randomized controlled trials, and you can see why. Imagine trying to do a randomized controlled trial when you say, okay, we're going to randomize 2 groups of people. In one group, okay, you're going to be taking methamphetamines. There's a lot of this research you can't do with people who have serious psychopathology or drug addiction or psychosis, and so there are major gaps in the literature, and so because of that, expert consensus differs from the high quality studies. Many variables never studied in randomized trials, which include addiction, dangerousness to self or others, psychosis, personality disorder, litigation. Typically, randomized controlled trials exclude all such patients. But expert consensus is that these risk factors may be more important than the more mundane yellow flag risk factors that Den-Boer and Celestin studied. So if we look at a table comparing presurgical risk to the rehabilitation risk score, the presurgical risk was developed using Den-Boer criteria. The rehab risk score was looking at a biopsychosocial theory of delayed recovery. The method for presurgical was more of an evidence-based method using systematic reviews. Rehab risk, clinical theoretical method, which looked at both empirical data plus expert consensus. Presurgical, the score is created by a scale. Rehab risk, the score is generated by an algorithm, which is basically the number of risk factors that are present. The presurgical risk score looks at the 9 or 10 risk factors predicted by, or identified by Den-Boer and Celestin, and rehab risk looks at over 30 risk factors. Some have less research, but are judged to be important by expert consensus. The presurgical risk was developed to predict multiple dimensions of surgical outcome: pain, function, distress, sleep, and dissatisfaction with care. Rehab risk was looking at two things: subjective satisfaction with care and something objective. Was the patient working? And so if you're able to work and have a job, that's an objective outcome that gets away from self-report and feelings. The pre-surgical risk score had a closer tie to high-quality studies in terms of validity, and rehab risk had a stronger association with the block risk score, which is, if for those of you who are familiar with that, that's also a clinical theoretical algorithm type score. But pre-surgical risk and rehab risk, even though they used very different methods, still correlated 0.82, which is, I think, evidence of convergent validity when you have two measures develop different ways that still end up producing predictions that intercorrelate pretty highly. So the pre-surgical risk score developed to predict the outcome of variables used by spinal surgery trials. And that's using what are called the impact criteria, if you're familiar with those. This will be discussed further in part 2 of this presentation. The pre-surgical risk score includes items that represent risk factors like pain, somatization, distress, and problems with functioning. So, interpreting the pre-surgical risk score, a low score indicates a low level of psychosocial risk factors for failing to benefit from surgery, and behavioral interventions are probably not indicated unless there are specific concerns identified. An average score indicates there's an average level of psychosocial risk. Behavioral interventions could probably reduce an average score to below average, possibly improving the prognosis for surgery. Whereas a high score on this scale indicates an elevated risk of failing to benefit or being dissatisfied with the surgical outcome. If the surgery is elective, consider offering behavioral interventions to reduce risks prior to the surgery. And if the surgery is medically necessary, the behavioral interventions are indicated perioperatively, either before, during, or after the treatments. In contrast, rehabilitation risk. Like the primary risk score, rehab risk is produced by an algorithm. Like the pre-surgical score, rehab risk assesses secondary risk factors. Unlike the pre-surgical score, rehab risk assesses a broader range of risk factors such as characterological disorder, history of trauma, litigation, and substance abuse. So how do you interpret the rehab risk score? A low score indicates a below average level of psychosocial risk factors associated with a poor treatment outcome. An average level, like pre-surgical, indicates an average level of psychosocial risk for being dissatisfied with the outcome of medical treatment. And a high score indicates an above average level of psychosocial risk factors for being dissatisfied with the outcome of medical treatment. Note, when we were developing a rehab risk scale, we weren't just looking at low back research, although that's where most of the good studies are. We instead looked more broadly initially at spinal surgery, so both back and neck, and we are also looking at other types of surgery, such as upper and lower extremity surgery. We looked at other treatment settings, like physical therapy, occupational therapy, work hardening programs, and also things that are quite different, like patients in treatment for traumatic brain injury. So what we found was that rehab risk doesn't just apply to surgical outcome, but it applies broadly to all forms of medical treatment that we looked at. If you think about it, that makes sense. If a person suffers from depression or anxiety or has a characterological disorder, or has a substance abuse disorder. Those risk factors are likely to interfere with response to any kind of medical treatment, not just spinal surgery. And the research we did supports that. Again, that's referencing Bruns and DeSorbio 2009. So how do you interpret these two scales together? So what if pre-surgical risk is higher than rehab risk? What this means is that the core risk factors identified by Denboer and Celestin were elevated. Those are the risk factors for which there is the most evidence, and so you should rely on the pre-surgical risk score there. But what about the reverse, if rehab risk is greater than pre-surgical risk? What that means is the less well-researched risk factors, like hostility, substance abuse, litigation, and so on, are playing a larger role than the core Denboer risk factors. Next, let's think about assessing problematic response to medication. When we were thinking about assessing risks for medical treatment, we were intending to produce one scale, but ended up producing two, pre-surgical and rehab risk, for reasons we discussed. When we were trying to develop a scale to measure problematic response to medication, we were intending to create one scale, but again, we ended up with two for the reasons I'm about to explain. Perhaps the best way to think about this intuitively is to consider a conversation between Bob and Dr. Cutter. And here, Dr. Cutter is listening to Bob, and Bob is saying, "I can't stand the pain anymore, Doc. I got to have more pain meds." And Dr. Cutter is wondering what to say. And he says, I'm wondering, have you had any problems with substance abuse? And so here Bob says, well, yeah, I've had a lot of trouble with drugs and alcohol in my life. And so that's one type of pattern. This is where a patient reports a substantial addictive history, with addiction being to drugs or alcohol. But there's also a second scenario. Now imagine, again, the conversation where Dr. Cutter says, any problems with substance abuse? And Bob responds, it scares me, but since my injury, I can't control my pain. I've got to have more pain meds. If you think about these two conversations, even though the surface behavior initially is the same, that is, demanding more opioids, the dynamics behind it are quite different. Let's look at an overview of these two clusters of items. In the first cluster, addiction history, there's items about history of substance abuse associated with a history of trauma, illegal behavior, characterological traits, being perceived by others as addicted, and a history of drug and alcohol treatment. Now in this case, these are drugs and alcohol, things which were either obtained illegally or have use associated with illegal behavior, like being arrested for driving while intoxicated. All those suggest a history of what's classically referred to as addiction. But the second cluster, we call addiction potential, here it seems to be associated with a medical condition which precipitated extreme pain, to which the patient responds with high distress, poor coping, and craves analgesic to relieve distress, both probably emotional and physical distress. In this case, the drugs are socially sanctioned, quite the opposite of illegal behavior. They're socially sanctioned, prescribed by a physician, and paid for by the insurer. Now, these two patterns in the literature are sometimes referred to as addiction and pseudo-addiction, in that both patients can present in the physician's office demanding analgesics or benzodiazepines or other medications, but the underlying dynamics are quite different. We actually thought about calling these two scales addiction and pseudo-addiction, although especially the term pseudo-addiction just seem to be too prone to misunderstanding. In particular, the word pseudo-addiction or pseudo-addict sounds like an addict who's also a fake. So while the term pseudo-addict isn't broadly used and doesn't have an accepted definition, nevertheless, it's a useful construct to think about as differentiating cluster 2 from cluster 1. One last point, despite the fact that these two scales sound a lot alike, they only intercorrelated 0.33, which we thought was remarkable. So even though both of these patients could be making excessive demands for medications, the two dynamics do not intercorrelate highly, suggesting that they are really distinct syndromes. So, if we think a bit more about the addiction history pattern, addiction is a neurobiological disease with genetic, psychosocial, and environmental factors influencing its course. And addiction to prescription medication involves using that in an aberrant and non-medical way, like taking your oxycodone, grinding it up, and snorting it, or smoking it with your marijuana, or taking your oxycodone with a six-pack of alcohol. So it's generally believed that a patient with a history of addiction in this sense, when presenting in the medical setting, if prescribed a medication which is potentially habit-forming, they could begin using that medication in aberrant ways as well. So how do you interpret addiction history? A low score means that there's no reported history of aberrant or problem drug-taking behavior. When interpreting this, always look at the self-disclosure score because patients with this history may not wish to disclose it. An average score here, I mean, there's an average level of problems with drugs or alcohol over the course of life. Many people have some use at some point in their life. A high score indicates a significant history of problematic drug-taking behavior along with addiction-related psychological traits. Now, this doesn't necessarily mean that the patient is currently using or addicted, just that they have had this pattern in their life at some point, and there's a risk that under stress, if given a medication on which they could become dependent, they are at increased risk for relapsing into old behavioral patterns. In contrast, if we think about the addiction potential cluster of items, this syndrome is thought to begin with a response to a painful injury or illness to which the patient responds with high distress, poor coping, and a tendency to rely on medications as a means of relieving pain and emotional distress as well. Unfortunately, a biological consequence of using some medications like opioids or benzodiazepines and others over a period of time is that the individual becomes tolerant of that substance and then begins to crave it. And over the course of time, the use of this substance may get out of control. And so this patient may not have had a history of addiction, but is at risk for developing a substance use disorder. Interpreting addiction potential. A low score indicates a low level of medication risk factors, and average score indicates an average level of medication risk factors. So average is not 0, and perhaps this could be reduced somewhat, but still it's in the average range, what a typical patient may exhibit. Many patients may have some desire for opioids just because of the nature of that medication. A high score in addiction potential indicates a high level of pain, dysfunctional beliefs about pain, high level of associated distress, craving the medication, anxiety about using the medication, but nevertheless feeling like you need it. So again, a distinct cluster of symptoms. The last set of scales on the MIR are scales which are assessing non-adaptive coping. Here again, the MIR looks at two distinct types of non-adaptive coping, catastrophizing and kinesiophobia. Now I should mention that kinesiophobia is sometimes used by different names. It's also sometimes discussed in the context of fear avoidance, but the two constructs are actually quite similar. Let's think about non-adaptive coping and how a person's cognitions about pain alter a person's response to a painful injury. If you look at the graphic here on the screen, you can see that in response to pain, some people may respond with catastrophized cognitions. My pain is horrible. It's unbelievable. It's I can't stand it. Now, when you think in a catastrophized manner, you're more likely to have an affective response like depression, anxiety, or anger. But what we know is that intense affect also tends to increase your stress level and pain perception. And so as your pain goes up, then you can catastrophize even more. And this leads to a downward psychological vicious circle, where the worse your pain gets, the more you catastrophize, the more you catastrophize, the worse your pain gets. But there's a second vicious circle. A person can respond to pain with the belief that exercise will injure me. I need to lay down. And so you can have dysfunctional self-protective behaviors. So this leads to activity avoidance, which leads to progressive deconditioning and a further worsening of pain. So kinesiophobia and the fear of exercise can lead to a physical vicious circle and a second downward spiral. Now you can look at these separately, or actually you can think about both of these things happening in tandem, where it's possible a person can both be catastrophizing about how bad their pain is, which increases their distress and pain, and using kinesiophobic cognitions to decrease activity of irrational self-protection, and also worsening their condition. So both of these things can happen at once. So let's think about conversations between Bob and Dr. Cutter. And this is a catastrophizing situation, and Dr. Cutter asks Bob, so what's your pain level today? And Bob says, the pain level you would call a 10, I would call a 2. And my pain level right now is a 20. It's beyond what you could even imagine. So sometimes people describe their pain in such catastrophized ways that it's really dysfunctional. So catastrophizing is related to behaviors that are adaptive. And what research has shown is that many animals will exhibit pain behaviors. It's a way of seeking care from others. The dog who's whining, a cat who's yowling, or other animals can exhibit pain behaviors, and it mobilizes the caretaking behavior of others. So when you're sick or injured, you might need to ask for help, and that's appropriate. But catastrophizing occurs when this gets out of control, and it's a cognitive process where an individual greatly exaggerates the negative consequences or circumstances in the attempt to get more help. Catastrophizing can disrupt the recovery process and increases the risk of chronic pain. Systematic reviews of the literature have found that catastrophizing predicts a negative treatment outcome, and so it's one of the risk factors used on rehab risk, for example. So interpreting the catastrophizing scale, a low score indicates a very low level of negative thoughts and beliefs and may suggest a positive coping style. An average score indicates an average level of negative thoughts and beliefs, nothing remarkable. And a high score indicates a tendency to exaggerate the negativity of your circumstances, especially as it relates to pain. Note, though, that on the catastrophizing scale, it's not solely about pain. and also looks at catastrophizing generally. Kinesiophobia. Again, Bob and Dr. Cutter. Dr. Cutter asks, how is physical therapy going? And Bob says, those exercises are way too dangerous for me. I don't want to hurt myself even worse, so I haven't gone to PT. So kinesiophobia can limit a person's willingness to engage in activity, and unfortunately, in many cases, patients don't recover without that physical activity. So if we review the concept of kinesiophobia generally, in some cases, it's adaptive. Like following an injury or illness, it's a good thing to exhibit some self-protective behaviors. If you fracture your ankle, you shouldn't be walking on it for a while. They may be on crutches for a couple of weeks and in a cast for a while and limited walking. Maybe a while before you should go to Zumba class. So some self-protective behavior is indicated following an injury or during an illness. But some patients take that to extremes. So kinesiophobia is an excessive, irrational, and debilitating fear of physical movement and activity. And that also predicts poor outcome for treatment from pain and injury. So interpreting the kinesiophobia scale. A very low score indicates a very low level of fear about physical activity and bodily injury, and could suggest a lack of self-protective behaviors. It could suggest risk-taking. People who push themselves too hard in physical therapy, try to do things prematurely. An average score indicates an average level of fear of physical activity and bodily injury, about what's normal. And a high score indicates excessive fears and self-limitation. So then, if we step back and think about how do you identify medical patients who might benefit from interdisciplinary care, as opposed to treatment via surgery or medication, who could benefit? One of the things that the MIR report does is to take all the information gathered and to make recommendations. What types of treatment might a patient benefit from? It looks at patient risks and patient strengths, recommends actions, recommends psychological treatments. This can be a helpful way of identifying which patients really need psychological treatment, and of those patients, what kind of treatment could they benefit from? It should be remembered also that if a patient is at high risk at the time of testing, it doesn't mean they'll be at high risk forever. Things like depression are treatable conditions. Even primary risk factors, patients are suicidal. They're not suicidal forever. Once they get through the crisis, their risk levels may decrease. So even if a patient isn't a good candidate for a surgery or interventional procedure at this time, given a chance to ameliorate those risk factors in appropriate psychological care, the patient may become a good candidate for treatment. Conclusions. The interdisciplinary biopsychosocial model is the accepted standard of care for many conditions. The MIR report can play a valuable role in interdisciplinary settings by identifying risk factors that could prevent a patient from benefiting from medical treatments, and by recommending behavioral treatments that can reduce these risk factors and help a patient better manage his or her symptoms. Thank you.